Hello everyone, my name is Kea and today I'll be presenting the individual research project. Let me share my screen. For this presentation, my topic is health services financing. Today, my special focus is how the transition to value-based care and alternative payment model is reshaping the business of US hospitals. The US healthcare system traditionally were paid under fee for service, a model that rewarded volume, which means like more tests, more admissions, and more procedures. But this led to fragmented care, rising cost, quality variation, the problems which are described throughout the systems framework in our textbook Xianxi. The reform direction today is toward value, where hospitals are paid based on quality, outcomes, and efficiency. My analysis will include insights from two informational interviews, one with the hospital CFO, Chief Financial Officer, and one with the Director of Population Health. We'll discuss about value-based purchasing and alternative payment model, which are at the center of this reform. Value-based purchasing adjusts Medicare payments based on hospital performance on measures like mortality, patient experience, safety, and efficiency. An alternative payment model includes accountable care organizations and bundled payment, like shift financial accountability to providers for total cost and quality. From the systems framework perspective, these reforms modify financial incentives, you can say care coordination, you can say data use. The output could like improved outcomes, lower avoidable utilization, and this kind of reforms are intended to correct system inefficiencies and encourage integration. My interview with the chief financing officer at a local hospital emphasized that the financial impact is direct and unavoidable. Under the value based purchasing, a percentage of diagnosis related group payment is withheld and redistributed based on performance, which means that hospitals can gain or lose revenue. The chief financing officer also noted that this creates financial volatility and pressurizes the organization to invest strategically in quality improvement. He explained that the value based contracts shift risk to hospitals, which requires actuarial analysis, forecasting, and careful management of high risk populations. He also stated that the risk bearing arrangement forced hospitals to focus more on preventing readmissions, reducing complications, and improving transitions of care. My interview with the Director of Population Health highlighted operational impact. To succeed under value based purchasing and alternative payment model, hospitals must implement strong data analytics, tracking real time quality metrics, readmission trends, and population health indicators. He explained that clinicians and administrators now rely heavily on electric health record dashboards, predictive analytics, and care management tools. Hospitals are hiring new roles, care navigators, population health nurses, and data analysis. This reflects a shift from an intuition driven model to a data driven learning health system. To manage risk and build capacity, many hospitals are now consolidating. Mergers and acquisitions allow hospitals to spread risk across a large population, negotiate better contracts, and invest in expensive technologies. The chief financial officer interview confirmed that his hospital is partnering with physician groups and purchasing post-acute facilities to control the full continuum of care. This integration is essential for managing bundle payment and ACO contracts, where outcomes outside the hospitals like home health and rehab affect financial performance. One major strength of this reform is the improvement in incentive alignment. Instead of rewarding volume, the reforms reward prevention, chronic disease management, and care coordination. Evidence from the Medicare Shared Savings Program shows that ACOs can reduce spending while maintaining or improving quality. The Population Health Director emphasized that clinicians feel more supported to focus on long term outcomes instead of short episodic encounters. These reforms push hospital toward holistic patient care rather than transitional care. Let's talk about the challenges. There are significant challenges. First, value-based models require expensive technology, data systems, EHR upgrades, analytical teams, posing barriers for rural and community hospitals. The chief financing officer stated that the early years of transition often result in negative margins because investments come before savings. Secondly, these models risk disproportionately penalizing for hospitals serving high social risk populations. From a social justice perspective, adjusting quality scores for socioeconomic factors is essential to avoid widening disparities. COVID 19 also revealed weaknesses, like hospitals which were dependent on elective procedures suffered major financial losses. Well, now let's talk about the comparison with the fee for service model. Under the fee for service, financial incentives were tied to volume, consistent with market justice principles, where services are commodities and consumers purchases care. But this created moral hazard. Providers could overuse services because more utilization meant more revenue. It also reflected market failure because prices did not correlate with quality outcomes. Value based care introduces elements of social justice, rewarding quality, prevention, and equitable access. From an economic perspective, this shift corrects misaligned incentives and seeks to optimize supply and demand more efficiently. However, it can be said that the value based care introduces new risk, transferring financial accountability to hospitals. The transition always creates opportunities, like hospitals can innovate in digital health, remote monitoring, and chronic disease management programs. The population health director mentioned that the value-based contracts allowed them to expand home-based care programs, which improve satisfaction and reduce readmission. Entrepreneurially, hospitals can diversify revenue through outpatient partnership, telehealth, and community health programs. These innovations would not have been financially sustainable under fee for service. Well, based on my research and interviews, I'd like to say that I support the transition toward value based care, but with significant reforms. I agree that aligning payment with outcomes is essential to controlling cost and improving quality. However, I also believe policy changes must address equity challenges and resource disparities. Hospitals serving vulnerable populations need, like socio-demographic risk adjustment, grants or low interest loans for IT upgrades, hybrid payment models to reduce short term financial instability. A gradual, flexible approach would promote both market efficiency and social justice, I believe. To conclude, I would like to say that the shift to value based care and alternative payment model is not simply a reimbursement reform, it is a transformation of the entire business model of US hospitals. Hospitals must recalibrate finances, redesign operations, and rethink strategy. Those that succeed will treat value based care not as a compliance issue but as a strategic opportunity to innovate. This is the end of my presentation. I have listed my references here. Thank you, everyone. Thank you for your time. Thank you.